Hi guys, good afternoon. Thank you for joining me today. This is the fourth video in the series that I'm doing about chronic stable angina. Today we're going to be talking about the drugs that are used in chronic stable angina for symptomatic relief. Now, these drugs don't have mortality benefits except for one of them, but they do improve the symptoms. And as you know, symptom management is an integral part of any management for any disease process. So let's go ahead and get started. So before I actually even go into discussing the drugs that are used for symptom relief, I want to take a moment to think, and I want you to think also, to try to conceptualize exactly what is the mechanism by which chest pain happens in chronic stable angina. If we can identify the mechanisms by which the chest pain happens, we can look at drugs that can block those pathways through which the pain is actually occurring. So let's look at the mechanism of disease pathogenesis in chronic stable angina. So as you know that in chronic stable angina, there is a stable atherosclerotic plaque in the coronary artery, which is reducing the blood flow to the myocardium. Now, this is very much different than acute coronary syndrome, and we will be discussing about acute coronary syndrome later. In acute coronary syndrome, it's an unstable plaque which ruptures, which causes the chest pain. That's why the spectrum of acute coronary syndrome starts with unstable angina. This is a stable angina. So the plaque is stable. It's not going to rupture. But obviously with a plaque in the coronary artery, it's occupying some part of the lumen of the coronary artery. So it's reducing the blood flow to the myocardium. So the blood flow is reduced, but still adequate to meet the heart's demand at rest. So patients with chronic stable angina don't have any chest pain at rest. Pain elicits when heart's demand for oxygen is increased at stress. So both physical and emotional stressors can cause tachycardia, and the heart's demand for oxygen will be increased. Or what is the other time when the heart's demand for oxygen will increase? The other time is when the heart muscle must pump against a high blood pressure. So always remember the concept of afterload. So if the blood pressure is high, the heart muscle has to generate enough force to pump against that blood pressure to get the blood out of the LV into the aorta. So the demand is going to increase. And so whether you have tachycardia or you have hypertension, in both these cases, when the demand for oxygen goes up, blood flow, blood supply cannot be increased to meet this increased demand because you have a plaque. So that causes the supply demand mismatch. But that's the pathogenesis. So now that we have looked at the pathogenesis, we can just address those steps that we looked in the pathogenesis to make sure how we can make a difference or how we can make the pain go away. So what if we reduce the demand of the heart for oxygen? We can reduce the demand by reducing the heart rate. If the heart has to beat in a minute 120 times, and if we can reduce it to 80 times, as you can imagine, the heart has to do much less work. So the oxygen demand will go down. We can decrease the blood pressure. So if the blood pressure is 180 over 100 against which the LV has to pump, we bring that blood pressure from 180 over 100, we bring it down to 140 over 75. Now all of a sudden the heart doesn't have to pump that harder. The demand goes down. Or we decrease the ventricular wall stress or tension. So if we can reduce the preload and reduce the amount of blood that's coming to the LV, it will cause less tension in the wall of the LV, and that will decrease the oxygen demand as well. And finally, we can improve myocardial oxygen supply by coronary vasodilation, which will help resolve the symptoms. So now that we have looked at this pathogenesis, it's easy to understand the drugs. So let's go through the drugs. The first one is beta blockers. Now remember, beta blockers also improve mortality. So they have dual effect. They improve mortality and they improve symptoms. So how are they going to improve symptoms? I've listed these three beta blockers here: carvedilol, metoprolol succinate, and bisoprolol. And the reason I've listed all three is those are the ones that are used for mortality benefit. So I just listed them here, but for symptom relief, you can use even other beta blockers that are not included in these three. But ultimately what they're going to do is they're going to reduce the heart rate, which will decrease the demand. They're going to reduce the blood pressure, which is going to decrease the demand. So they primarily work by decreasing the demand. They do not increase the supply. So once you've started the beta blocker, you can titrate the dose to keep the heart rate between 55 to 60, which is what is the target when we are using these drugs for chronic stable angina. Now you can also use calcium channel blockers in patients intolerant to beta blockers. And you can also add calcium channel blockers to beta blockers for additional benefit, but you need to watch out for severe bradycardia and hypotension because of their negative chronotropic and inotropic effects. You can really drop the heart rate, especially if you use non-dihydropyridine calcium channel blockers, and you can cause hypotension as well. So whenever you're combining beta and calcium channel blockers, please watch out for that. Now, if you use the calcium channel blockers just by themselves, they also reduce the heart rate and decrease demand. They also reduce the blood pressure and decrease demand, but they cause coronary vasodilation, which improves the supply. So you remember that there in the smooth muscle of the walls of the blood vessels, there are receptors for calcium. If you block the calcium, that can cause some relaxation of the smooth muscle in the wall of the blood vessel. That can cause relaxation of the wall and improve the blood supply. That's one thing that beta blockers don't do that calcium channel blockers do. And then just be careful. Do not use calcium channel blockers in patients with systolic heart failure or in those who have a low ejection fraction. It can cause heart failure exacerbation. Because again, like I said, they have significant negative chronotropic and inotropic effects. So you don't want to give these drugs to patients who have heart failure, systolic dysfunction. Okay, the next drugs that can be used are nitrates. Nitrates improve symptoms, don't have any effect on mortality. And they actually also have both the effects. They cause coronary vasodilation to improve the supply. They also reduce ventricular wall stress by reducing the preload, which decreases the demand. With nitrates, always be careful to give a 12-hour nitrate-free window every night to avoid nitrate tolerance. And the last drug is ranolazine. It's been around for a long time now. And basically its mechanism is that it reduces the ventricular wall tension by reducing sodium-dependent calcium currents. So it also decreases the demand. So again, these sodium-dependent calcium currents are very important in the ventricular wall stress or tension. When you reduce these currents, you cause the ventricular wall to relax a little bit, and that means that the oxygen demand is not going to be as much as it would have been if there was no relaxation of the ventricular wall. All right, guys, thank you for hanging on for this presentation with me. Please subscribe to my channel, and I'll see you in the next video.